Good evening, everyone. Myself, Dr. Lavanya, nephrology final year trainee from Nizam's Institute of Medical Sciences, Hyderabad. I welcome you all to virtual session of Central Zone chapter of Win India. As a part of World Kidney Day celebration, Win India has organized day-long sessions through various state chapters. After listening to excellent talks from various state chapters since morning, that is from Karnataka, Hyderabad, Andhra Pradesh, Kerala, and watching beautifully executed mime, which was out of the box thinking from Tamil Nadu and Pondicherry team. I now welcome all of you to Central Zone chapter. I now invite Dr. Isha Tiwari ma'am, Secretary Win Central Zone, to deliver talk on World Kidney Day 2023 theme that's preparing for the unexpected, protecting the vulnerable. I invite chairperson for this session, Dr. Pradeep Salja, sir, Senior Consultant Nephrologist and Transplant Physician Indore, Dr. Swarnalata Madam, Professor, HOD, Nizam's Institute of Medical Science, Hyderabad, Dr. VP Pandey, sir, Professor and HOD, General Medicine, MGM Medical College, Indore. Welcome, everybody. Moving over to chairpersons, I request chairperson to briefly introduce speaker. Thank you.
Thank you, Isha. So as you said, we have come to the last session of the day. We had a marathon of webinars since morning covering all the chapters. So now is the central zone. We are ending the central zone chapter. So we would now request the secretary of the central zone, Dr. Isha Tiwari. She's assistant professor of nephrology, MGM Super Specialty Hospital, Indore. And she'll be talking on the theme of this WKD 2023. That is the preparing for the unexpected and protecting the vulnerable. We had several discussions since morning. I think she'll add on to the new insight into how we have to prepare for the unexpected and protecting the vulnerable. Over to you, Isha.
Thank you so much, ma'am, for that kind introduction. Of course, we had a deluge of webinars since morning. It was a marathon, definitely. And all the state chapters, they've done their part in contributing to the cause of World Kidney Day. And what the theme this year is all about, I'll be sharing with you all here. So on behalf of Women in Nephrology India Central Zone chapter, which comprises of 4 states of Rajasthan, Gujarat, MP and Chhattisgarh, I shall be speaking about the World Kidney Day theme 2023. So moving ahead, let's see the background of why at all do we need to celebrate something like a World Kidney Day. So it's a global campaign which is aimed at raising awareness for the importance of our kidneys. And the basic philosophy here is kidney health for everyone. It's a joint initiative of the International Society of Nephrology, ISN, and the International Federation of Kidney Foundations, World Kidney Alliance, IFKF and WKA. It began to be celebrated in 2006 with unique and relevant themes being propounded each year. So talking about the theme this year, it's preparing for the unexpected and supporting the vulnerable. So the keywords here which we'll be talking about is unexpected and vulnerable. The relevance of this theme is that in the event of emergencies like natural calamities, pandemics, people with kidney disease are the ones who are the most vulnerable in the population. If we talk about any natural calamity in the form of disasters like earthquakes and floods, or pandemics like the unfortunate pandemic of COVID, which we had recently faced, it would affect the general population and inflict disease upon their kidneys. This would result in something like AKI or acute kidney injury. In the other way, it may also affect the CKD population, who either would have logistics and follow-up issues for nephrologist visits, or hemodialysis and procuring immunosuppressants if at all they're post-transplant. So what the ISN has propounded this year is that there are 11 key principles which are responsible for maintaining an unchaotic state in the face of or event of any natural calamity or disaster, which would include planning process, collaborating networks, community engagement, risk analysis, surveillance and monitoring, practice and experience, resources, workforce capacity, communication, learning and evaluation. If we talk about it, we know that social media is a double-edged sword in today's era. So there might be some miscommunication of information, or there would be some fake information which is being transmitted in the face of any natural calamity. So the responsibility of the governance and the leadership, or the governments as a whole, is that such false information is not being disseminated among the population, and the collaborative network, community engagement, and the communication part is strong. So we'll say that superficially, it might be said that the function of the kidneys is to make urine, but in a more considered view, one can say that the kidneys make the stuff of philosophy itself. So let the celebration of the World Kidney Day begin. Thanking you all.
Thank you, Isha. That was a very elucid presentation on what is the theme and how to go about it. So over to the next co-chairpersons for their comments, please.
Isha, you rightly said that in post-COVID issue, we have been seeing so many complicated issue, and at that time also the kidney became the most important organ. But otherwise also, keeping kidney in mind has always been the center of management for any patient, any doctor who is managing patients. So you have rightly said, we have to see that the organ should be prevented as soon as possible and should be managed appropriately. So go ahead with the second comments now. Thank you.
Last month, we had a bad earthquake in the Turkey. And there were some feelings that probably some effect of earthquake may come to our country also. Similarly, in our north, we had a problem. So I was wondering that how relevant was the topic this time of the World Kidney Day, right? Because these calamities, natural calamities, are likely to occur with anybody in any country, any part of season or time year. So we should be prepared for the relevant renal problems to be tackled with. We should have all the well-planned efforts to deal with the renal problems which are likely to occur during this time. So I have very strong feeling that the topic for World Kidney Day is very relevant, and probably if we are prepared to deal with calamities, I think which were not earlier, so we'll be able to treat more renal problems and prevent all acute kidney injuries which are occurring with the natural calamities. I think that's from my side.
Thank you, chairpersons, for your comments, and thank you, Isha, for setting the stage for the next discussion. Over to the organizers, please.
Thank you, chairpersons. Thank you, Isha ma'am, on highlighting World Kidney Day's theme. It was a crisp presentation. Moving on to next session, I now invite Dr. Padmini ma'am. The topic of this session is home hemodialysis, the panacea. I now invite chairpersons for this session, Dr. Manjusha Yadla ma'am, Professor HOD, Gandhi Medical College, Hyderabad, Dr. Sonia Gupta ma'am, Consultant Nephrologist, Kidney Care Hospital, Udaipur, Dr. Anand Chalapan sir, Assistant Professor Nephrology. I now request chairperson to briefly introduce the speaker. Over to you, chairpersons.
Thanks, Isha. Thank you so much. Thanks, Lavanya. Thank you so much. We're happy to be here. This is the ultimate session of the long haul that we had been having since morning of the Win India sessions on the occasion of the World Kidney Day. So after the introduction by the Central Zone on the theme of the World Kidney Day, we move on to another interesting topic. That's the home hemodialysis, the panacea. This would be spoken by Dr. Padmini Kanungo, who is active in the social media as well as in all the Win India activities. She is a consultant nephrologist from Assistant Professor, Department of Nephrology, SIMS, Indore. So we are all ears to hear from Dr. Padmini to learn about home hemodialysis, the panacea. The floor is all yours. Padmini, over to you.
Yeah, thank you, ma'am. And thank you for that kind introduction. So without wasting any time, I'll move to my topic of home hemodialysis, the panacea. Well, whether it's the panacea or not, I'm not clear, but it is definitely the road less traveled in the present times. In fact, the story was not always like this. The idea of home hemodialysis began in Japan in 1961 and subsequently was put into practice simultaneously at 3 different places in the world, that is in Seattle, Boston, and London. That time, the hemodialysis that was being done was 2 to 3 times per week. And D. Palmer in Los Angeles introduced us to the idea of daily hemodialysis for chronic kidney disease. This was the first home hemodialysis patient in Seattle in 1964 undergoing home hemodialysis. But in the 1972, a legislation that was passed by the United States of America government meant a major blow to the home hemodialysis program, which had been running for almost a decade. And that meant that there was a universal coverage that was being given by the insurance companies, which favored the for-profit dialysis center hemodialysis. And because of that, home hemodialysis took a backstage. By 1980, only 4.6% of patients with ESRD were on home hemodialysis in United States. The situation was no different in Europe. Only Australia, New Zealand, and Turkey were the 3 countries in the early 2000s who were having a substantial portion of home hemodialysis patients. In 2005, again, when the US government came up with a new law and home hemodialysis equipments were approved by the US FDA, some progress was made in this field. But it was a turtle pace from 2005 to 2019 as far as home hemodialysis was concerned. In the United States in 2016, only 1.8% of prevalent patients were on home dialysis and only 0.3% of the patients were beginning their dialysis with home hemodialysis. The world scenario was no different. You can see that this distribution of RRT modalities that has been taken from an article in CJASN shows that the entire sky is blue or pink. Home hemodialysis, represented by yellow color, is hardly visible in this graph. But if that was the dismal state in 2016, why talk about home hemodialysis in 2023? Well, obviously, the answer lies in the year 2019, when we faced COVID-19 pandemic. We saw that our patients struggled in making to the hemodialysis unit. The hemodialysis unit struggled in segregating our patients who were positive and negative, and all this resulted in increased morbidity and mortality for our patients, and ultimately a renewed interest in home hemodialysis program. So we would say that the turtle got a skateboard to move on. So in 2023, post-COVID, we are looking at 3 scenarios. Post-COVID has made us ponder our strategy for hemodialysis. Second, there are enough literature now to support home hemodialysis as an option for a selected group of patients. And third, we have newer machines and technology to support home hemodialysis. But before we move on to what is new, we should at least understand what is home hemodialysis after all. Home hemodialysis is a form of renal replacement therapy, which the patient is taking at home. This offers the patient to have more frequent dialysis sessions at his own convenience, allowing him to take control of his treatment. Patients on hemodialysis who are anuric are spending about 93% of their time accumulating salt and water, and merely 7% of the time is given to their treatment, whereby all this extra salt and water has to be removed. If you aim for a removal in a very short period of time, they suffer the problem of myocardial stunning, hypertension, dizziness, and nausea. So that brings us to a question: who is suitable for home hemodialysis? Well, any patient who is suitable for in-center hemodialysis is suitable for home hemodialysis. Only if the patient is severely ill, or if the patient is having some issues, be it with dexterity or with mental status, then only he cannot take home hemodialysis, otherwise he can. Specific category of patients who benefit more with home hemodialysis are patients who have their pregnancy, patients with refractory hyperphosphatemia, patients with hemodynamic instability, or those with cardiovascular diseases who require low ultrafiltration rates. A home hemodialysis obviously requires a motivated and committed patient towards hemodialysis in the home. He should be clinically stable. Education, maybe a basic level education would do, but he should be well versed to follow the instructions that are given to him. And if he wants a flexible lifestyle, then he's a candidate for home hemodialysis. What are the barriers to home hemodialysis? Interestingly, this article by Lloyd says that most of the time, the patients are pretty satisfied taking hemodialysis in a hemodialysis unit because they think the medical staff is around and they are not responsible for their treatment. But Apart from that, one more reason which these authors concluded was that most patients who chose home hemodialysis did not actually receive home hemodialysis. And this happened because of potentially reversible barriers of inadequate communication among clinicians and patients changing their mind once they are in dialysis unit. Fear of needles is obviously another important issue, which is a big hindrance to home hemodialysis. So how do you reduce that fear of needles? The dialysis, once the dialysis staff is there, they should involve the patient in the preparation of cannulation techniques. They can advise that these home hemodialysis patients use warm compressed topical analgesia. And the best way possible is that if somebody is self-cannulating in front of them, then that is going to be the biggest boost to these patients who have fear of needle when it comes to doing home hemodialysis. So we see that it's going to be an integrated approach to home hemodialysis, and this integrated team would involve nephrologist, a home training nurse, a renal dietitian, and may or may not be a social worker and a home care partner. So there are several types of home hemodialysis programs from which to choose for, but basically there are three important ones. First is the traditional home hemodialysis sessions that we know it's similar like you have for your in-center hemodialysis, that is 3 times per week with each session lasting 4 hours. Then you have the short daily home hemodialysis sessions, which are about 5 to 6 days per week. And each session is lasting from somewhere between 2.5 to 3.5 hours. And then you have the nocturnal home hemodialysis program, wherein it is about 6 nights per week for 6 to 8 hours. The conventional home hemodialysis is similar to the in-center one. The short daily home hemodialysis helps in reducing the symptoms of headache, nausea, cramping, and feeling of washed out because you're removing little fluid each time. Nocturnal home hemodialysis is basically meant more for patients who have refractory heart failure, refractory intradialytic hypertension, or pregnancy. Intensive home hemodialysis is indicated for patients who have persistent hypertension, left ventricular hypertrophy, heart failure, recurrent intradialytic hypertension during their HD sessions, post-dialysis fatigue, or refractory hyperphosphatemia. Which machine to use for? And I quote this from an article. Any currently available hemodialysis machine is capable of providing home hemodialysis. No particular machine is or should be considered to be a requisite for good, sustained, and effective home hemodialysis. Thus, the answer to the question, which machine is? Any machine as long as it meets the patient's specific needs and requirements. So you have 3 options to choose from. The conventional hemodialysis machines that the ones which we are using in our in-center hemodialysis, and the 2 newer ones, the NX Stage System 1 and the Tableau HD machine. So how would the hemodialysis prescription vary with each of these machine types? When it comes to the conventional home hemodialysis that is given by the machines that we are using in center, it's going to be in the similar fashion as it is in our hemodialysis units. Obviously, if you want to give a short daily or a nocturnal hemodialysis with these machines, then accordingly, you can change the prescription. The NX Stage System 1, which is a new machine, and this machine has got slower dialysate rate and fixed dialysate volume. Now, this machine has got a somewhat complex prescription, hemodialysis prescription, in the sense that you are going to mention the total volume of dialysate to be used. This is going to be similar to the way you are prescribing in peritoneal dialysis. Along with that, you would mention the blood flow rate, the ultrafiltration rate, and automatically then the machine is going to calculate the dialysate rate and time. A concept which is unique to this machine is the concept of flow fraction. And so when you're prescribing a hemodialysis prescription on this machine, you would be targeting a flow fraction less than 30%. The maximum dialysate compartment flow rate that is permissible with a standard System 1 NX Stage machine is 12 liters per hour. The newer versions allow us to go as high up as 18 liters per hour. The water treatment system that is associated with this NX Stage technology is what is called as the pure flow system. And this pure flow system ensures that high quality water is delivered when you're using the NX stage technology. Along with the other water purification system that you can use is the portable water purification system, which is basically a miniature form of the water purification systems that we are using in our hemodialysis units. The third machine that can be used for home hemodialysis is the Outset Medical Tableau machine. It is the most recent addition to the home hemodialysis armamentarium and was approved for use by the Food and Drug Administration in 2020 after a multicentric safety trial. The Tableau machine is reported to be relatively easy to set up and has an incorporated reverse osmosis system. During the initial trial, the treatment was given 4 times a week for 3.4 hours, and a targeted KTV was kept at 2.1. The Tableau system has got its own internal water treatment system. Unlike the NX1, where it was outside, this has an inbuilt system. But the problem is that because of this, the water production does not occur as quickly as with the conventional hemodialysis machine, which limits our dialysis rates. If you're using the conventional home hemodialysis machine, apart from the plumbing requirements that you would normally require for an setup of a water treatment plant, you should always have a backflow preventer. You should ensure that the water supply is sufficient water supply, because you'll be needing 500 mils per minute to 1500 mils per minute of water. And it is recommended that the RO machines that you'd be using use the flow fed technology rather than the pressure fed technology, so that when the pressure drops down, the RO machine does not malfunction. Which access to prefer when it comes to home hemodialysis is your choice. You can use a fistula, you can use a hemodialysis catheter, you can use a graft. Which technique for self-cannulation of an AV fistula? Again, buttonhole or rope ladder, whichever is convenient. You can have some modifications, like you can use a polycarbonate peg to create a buttonhole. And in this method, actually, once you have cannulated, after the session, you're going to insert the peg at the same point, and that peg is removed before the next dialysis session, and then the patient can put in the needle at the same place. By repeating this technique for 8 to 12 times, you would actually be creating a proper buttonhole and making it easier for the patient to cannulate. Anticoagulation in this circuit is going to be no different. Most of the time in home hemodialysis, you are only going to require a bolus dosing of heparin, until and unless, of course, if you are going in for nocturnal hemodialysis, in that case, you may require an hourly infusion of heparin as an add-on, or you could use a low molecular weight heparin to begin with. So this is how a home hemodialysis room would look. It should be well lighted. It should be clean. You should avoid carpets and curtains. It should have a good connectivity. When you are discarding the waste of those home hemodialysis program, it is very important that you take care of the environment. The water that is being discarded can be used for green dialysis. Emergencies at home hemodialysis, well, virtually you can have all sorts of emergencies which you are seeing in a unit-based hemodialysis at home. But if you go through the literature review, there have been only reported 9 fatal cases, and all these 9 cases, out of these 9 cases, 7 cases were associated with blood loss. So check in the circuit properly before home hemodialysis start, and that is the way you can prevent these emergencies. In the worst possible scenario, if because of any reason the patient becomes unconscious or becomes debilitated while on home hemodialysis and he himself is unable to disconnect himself from the machine, the room should always have simple instructions at the bedside of the patient, preferably with a diagram, so that any person who enters the room can stop home hemodialysis. So when should we be talking about home hemodialysis? Well, when the patient is about to begin hemodialysis, he should be given an option of home dialysis in addition to in-center hemodialysis and transplant. Once he decides to go ahead with home hemodialysis program, then the one hemodialysis unit is going to supervise all the function. A nephrologist would take care of the prescriptions and the laboratory parameters. And then obviously you have people coming in from the community in the form of NGOs who would be supporting the patient so that he can carry out home hemodialysis in a convenient manner at home. How much time is required for a patient to undergo training before he can actually do home hemodialysis? Well, as you can see now, these are the hemodialysis units across the world, and the patients required anything from 2 weeks to 28 weeks, depending on various factors, to fully train themselves before they can embark on the journey of home hemodialysis. So a home hemodialysis program definitely requires a good hemodialysis unit, which would be a training facility for the patient. There is a concept of home hemodialysis hub in the US, which is developed, and it is similar to a hemodialysis unit, except for the fact that the patient does all the hemodialysis by his own, and the medical staff is there to supervise and guide, but the entire procedure of hemodialysis is done by the patient himself, as he would be doing in his home. So the way the hemodialysis units are going to train you to do a home hemodialysis is that they may actually ensure that you do 4 to 5 hemodialysis in the unit and then move on to home. And there would be certain other dialysis units which would prefer that you start with home hemodialysis right from the word go. So does it mean that if you are single, you cannot do home hemodialysis because there is a point of caretaker or home care person being mentioned? Well, interestingly, 0.25% of patients in the United States who require dialysis are unmarried or widowed. And so being single is not a contraindication to home hemodialysis program at all. And people are successfully doing it in high-income countries. So what are the benefits of home hemodialysis? Once you start on home hemodialysis, you would see that there is better blood pressure control, better phosphorus levels are achieved. There would be significant reduction in the left ventricular mass and left ventricular hypertrophy. There would be lesser episodes of hypertension, lesser cramps being reported, lesser dialysis fatigue, and lesser erythropoietin requirement. What is the social advantage? The patients can choose time for treatment. They have more flexibility for work or school or other social activities. Patient has no need to leave home for treatment, which saves on travel time and transportation costs, which you obviously understand went so high during the COVID time. Plus, it also elevates the weather-related travel worries. Home hemodialysis allows for a gentler correction of the metabolic milieu with more frequent and lower volume ultrafiltration, which is likely to promote more frequent stability during the dialysis treatments and lower the symptom burden. Also, the 2-day break from the dialysis treatment, known as the deadly dialysis weekends, are avoided when you are dialyzing at home. So does home hemodialysis provide a survival advantage? Well, if you look at the data and when you search the internet, it has been reported that home therapies have been associated with improvement in patient survival in most studies, but whether this is causative or there are confounding factors which are contributing to it needs to be answered. Another problem when you interpret these studies is that home hemodialysis umbrella includes conventional hemodialysis, short daily dialysis, nocturnal hemodialysis, and peritoneal dialysis. So all this makes the interpretation of data when you're going through the literature to assess whether home hemodialysis is providing a survival advantage or not, a little bit difficult because there are no direct RCTs comparing it, plus the groups that are comparing are pretty heterogeneous. Some people have tried to address this issue, like you have a review by Vincent et al., which came to the conclusion that home therapies have been associated with an improvement in patient survival in most studies, but whether this is causative or simply a reflection of a healthier population being selected for home therapies remains unclear. Similar was the view about systematic review that was done by Mowat, and they too concluded that home hemodialysis was generally associated with better outcomes than hospital hemodialysis and more modestly so, satellite unit hemodialysis in terms of quality of life, survival, and other measures of effectiveness. But on the flip side, they too agree that it's a highly selected group of patients who are offered home hemodialysis, and therefore home hemodialysis, it's difficult to disentangle the true effects of home hemodialysis from such influencing factors. Another review by Jihan has said that home hemodialysis not only improves the clinical outcomes, the quality of life, but in long term, it is more cost effective than in-center hemodialysis. The frequent hemodialysis network in their daily trial demonstrated a significant reduction in left ventricular mass by cardiac magnetic resonance imaging with home hemodialysis, though the result did not attain a statistically significant value in their nocturnal trial. So in the Indian context, if we think of home hemodialysis, how much is it going to cost to the patient? Well, the machine roughly would cost somewhere between 5 to 6 lakhs. An RO plant installation would cost somewhere between 1 to 1.5 lakh. Electrical and plumbing requirements would another lakh, and the bed, depending on what type of bed the patient chooses, can go up to a lakh. And the recurring cost, that is the tubings and bloodlines, are going to be similar as you have for the in-center one. So once the installation process is completed, the dialysis per episode is going to range between 6,000 to 8,000. And I know that is going to raise a lot of eyebrows, but look at this. The first mobile phone cost, if most of you would remember. So technology is advancing, and therefore we should definitely look in for home hemodialysis as an option. Just to summarize, that this is basically meant for people who are having urine volume less than 250 ml per day, a serum phosphorus more than 8, ultrafiltration rates during hemodialysis session requirement more than 13 ml per kg, who have uncontrolled hypertension, who have moderate left ventricular hypertrophy, who have obesity, who are having a full-time employment, who have transportation problems, who are concerned whether a PD catheter in situ would look bad on them. It's definitely not meant for people who are who have a lot of anxiety, or who have phobia, or who are having some degree, severe degree of visual impairment. So this brings me to the last slide, that is home hemodialysis is not easy, nor is it difficult, but with proper training and attention, you can deliver it. Getting started on the program takes time, patience, and commitment, both from the patient and the nephrologist. And I conclude by saying that not every patient will be suitable for home dialysis. However, every suitable patient should be offered this choice. Thank you for a patient listening.
Thank you, Dr. Padmini. It was an excellent talk. I think you have touched on every aspect of the home hemodialysis. But when it comes to Indian scenario, as you've rightly pointed out, I think the selection criteria should be, for the eligible patients, meaning to say that we need to select the patients appropriately. Health literacy is important of just not the patient, but as well the family, and the home setting also should be equally good. And of course, the main crunch in Indian scenario is the finances, as you agree, as you had projected the cost as well. The finances is definitely a negative factor once it comes to the home hemodialysis. Only a major group of patients, a minimal number of patients who can have certain affordability can think about home hemodialysis. It cannot be applicable to the all the patients who, in fact, majority are below poverty line, as we all know. So that way it is definitely a difficult one. But then education, counseling, like CAPD, it used to be like that. We counsel the patients, we train them. So such much amount of training is crucial. And of course, in the background of the World Kidney Day perspective of 2023, like preparing for the disaster, I feel is probably a good one, or maybe a double-edged sword, I don't know, because the patient can be at home, not reaching the torrential rains, or probably a quake or a disaster or a COVID pandemic for that matter, a man-made disaster. The patient is at home, can have the luxury of undergoing dialysis, need and skip dialysis, provided the stores are good enough of the disposables. So that way, I think home hemodialysis is definitely an entity that needs to be looked upon. in our country as well, maybe started in a big way by the private sectors. But when it comes to the government sector, only a thought, what similar to like a restaurant, probably hemodialysis restaurant can be there, wherein the machine and the disposables are available. The patient walks in, have a self-service, does the dialysis and gets out of there. But in all these situations, what we need is a support from the physicians. A tele monitoring also should be equally available, because as you pointed out, the emergencies should be handled in an appropriate way, so that this entity is definitely trusted upon. An excellent talk, a very good presentation. I think I hand over to my co-chairs for the further comments. Over to you, the co-chairs. Dr. Anand, if you're here, please take over.
Yeah, I think it was a very exhaustive and well-executed presentation. You have covered all the aspects, starting from the history of home hemodialysis. What's surprising is the concept had come early in the 1960s, but never materialized even in the well-developed countries. So I think it's a little too early to say it's the panacea, but there's a long way to go. And it would involve multiple stakeholders, patients, physicians, and also the policy makers. So as you rightly pointed out, there are so many challenges, but these are not unsurmountable. Possibly over time, these can be very well achieved. Especially in a country like India, we have a lot of challenges, especially as Madam had pointed out, the financial implications are big for patients, those who are coming from the rural setups. And even the physicians, I feel a component of training should be introduced. It's good that now we have the concept of home hemodialysis being discussed widely. So it should be a part of discussion, should be a part of the postgraduate programs. And there are some concepts in at least overseas where they have these transitional units where you have patients who are being prepared for home hemodialysis. They've been given a training or running in period in the in-center hemodialysis program. So something of this sort on a long run can be incorporated into the postgraduate education programs as well, so that students get to know, because unless we are sure about what we are advocating, we would not convey it to the patient. That's what I've seen. Even when we see we are struggling with PD and to materialize PD in the public, and being in the government sector also, there's so many challenges. So I think everybody has to pitch in, and it's a long way to go. And for policymakers also to address these costs and include these forms of therapy in the insurance schemes would be an important thing, which should also be put forward going forward as a community. But then very excellent talk, so many points to take home from the talk, and a lot of practical tips as well. Thank you so much. Enjoy the talk. Yeah.
Thank you.
Dr. Sonia Gupta, she is also the co-chair with Padmini. I think Dr. Sonia Gupta is here. Can we have her comments too? Dr. Sonia Gupta?
Yes, ma'am. Thank you so much. Dr. Padmini, it was a very lovely talk and I thoroughly enjoyed it. And I really didn't know that there are so many things that you could have actually included in the presentation. It was very nice. The place where I am practicing, what I feel is that since I am in an area where basically even the awareness of dialysis is so poor, like I have to convince the patients to make them understand that dialysis is not life-threatening. The moment we counsel the patients about dialysis, they get scared. They feel, okay, this is the end of life. I don't want to go ahead. And they actually refuse dialysis in the hospital outright. So like getting into a home dialysis program is unthinkable for this category of patients. Definitely this would be different in a metro city. I'm not in a metro. So maybe the way I face the challenges are different. For me, even just to make a patient come regularly to my center or to any center and to convince them that, yeah, dialysis is what you need is itself very difficult. And secondly, the government schemes have come in. There are so many programs which the Government of India as well as Government of Rajasthan is promoting, where there is a free treatment for patients for in-hospital dialysis. So even in such a situation, I think home dialysis is still a long shot. But it was a very nice presentation, and my co-chairs have already spoken so well about the different aspects, so I don't think I need to go back to them. But basically for us, at least in small cities, maybe convincing the patient for dialysis, that awareness is itself so low. So it will be a bit difficult thing, but yes, definitely it was a good talk and I really enjoyed it.
Thank you so much.
Yeah, just a question to Dr. Padmini. Is there
Yes,
any Indian literature that is there except for the one, the guidelines which have come up or, criteria? Is there any Indian literature on home hemodialysis in India? Because ours definitely is an LMIC, though we move on to UIC, ours is as of today LMIC. So is there any experience that's been put in literature regarding the home hemodialysis? Some short experience and from one of
No,
yours?
ma'am, I'm really
Or-
sorry. I apologize, but I'm not aware about this.
Okay,
Maybe somebody.
okay. Yeah. I think an excellent talk, Padmini, and all the excellent comments from my co-chairs. Thank you so much
Thank
for the
you for all the
opportunity, Dr.
encouragement.
Isha and the team. Over to organizers. Dr. Lavanya, over to you.
Thank you, ma'am. Thank you, Dr. Padmini, ma'am. It was an excellent session on home hemodialysis, on highlighted about how home hemodialysis requires more motivation and commitment compared to in-center hemodialysis, and discussing barriers towards it, and how an integrated approach will remove this barrier. Thank you, chairpersons, and thank you, speaker. Moving on to next interesting session on initiating dialysis in pediatric population. I now invite speaker Dr. Pramila Adhikari, ma'am, and chairpersons for this session will be Dr. Manisha Sahay, ma'am, Professor HOD Nephrology, Osmania Hospital, Hyderabad, Dr. Shilpa Saxena, ma'am, Pediatric Nephrologist, Apollo Hospital, Indore, Dr. Kinnariwala, ma'am, Associate Professor, Pediatric Nephrologist, IKDRC, Ahmedabad. Over to chairpersons. I request you to briefly introduce the speaker. Thank you.
So thank you very much for inviting us here. And it's really wonderful, the last series of Win India webinars. So great show so far. I really enjoyed the previous talk. Now coming over to this talk, initiating dialysis in pediatric population is all the more difficult. Pediatrics, the patients come in all shapes and sizes, newborns, infants, you have young children and older children as well, and adolescents. So it's not as simple as the adult, where at least a single size may still fit all. Pediatrics, it's all the more difficult. You have to take the patients into confidence. You have to convince the patients. You have so many machines available. You have to remember the sizes of the catheters, dialysis. So it's a big challenge. And I congratulate the pediatric nephrologist for doing an excellent job. Now, I would like to invite the speaker of this session, Dr. Pramila, who's Assistant Professor at MGM Medical College, Indore, to deliver her lecture on how to start pediatric hemodialysis. Looking forward to your talk. Please go ahead. Floor is all yours.
Thank you, ma'am. Good evening, everybody. I'm Dr. Pramila Ramawat, and my topic for today's webinar is when to initiate dialysis in pediatric population. So when I first get this topic, I thought why this topic is so important, initiate dialysis and in pediatric population. So after literature survey, I found that it is the most critical decision, which is subjected to too much controversy and no clear-cut recent guideline about when to initiate dialysis in pediatric population. Who will be decision maker for this initiation of dialysis? So as per national guideline in the National Dialysis Program, a nephrologist should take decision to initiate dialysis. In case if non-nephrologists start the dialysis in case of emergency, then within 4 weeks, it should be reviewed by a nephrologist. Why pediatric population? Emphasis on that topic. So pediatric population are not little adults, they are totally different. Why they are different? Their sizes are different from 1 kg ELBW baby to an adolescent of 70 kg, a small newborn baby to a full adult height of adolescent. So their size and their weight vary. Not only size and weight, growth and development is also an important issue for pediatric population. During this period, their neurological development, physiological development, and psychological development and maturation is going on. So it affects them a lot. Next important issue is equipment. Till recent past, there are no proper equipments available
below 5 years of age, although now they are available, but not in resource poor settings and not in peripheries. So still equipments are a big issue for pediatric population. Then technique, in small children and infant, intravascular access, IV access is a difficult issue. So to reach to an IV site like internal jugular vein or femoral vein is difficult, especially internal jugular vein. And then second important issue is peritoneal dialysis. So in ELBW babies, peritoneal dialysis is also an important issue. Otherwise, below 5 years, it is a good option for dialysis. So who need dialysis? Again, according to duration, acute indications like AKI and chronic indications like CKDs. If we decide indication based on age, then children and newborns have different criteria and guidelines for their management and initiation of dialysis. AKI, if we see 26 point, as per literature, 26.7% of PICU patients have AKI and 5.8% among them need renal replacement therapy. 25 to 50% patients develop chronic kidney disease, while 10 to 12% of them need dialysis in next 5 years. Mortality rate is also very high in PICU patients with AKI who need dialysis. These are the indications by Nephrology Society published in Indian Journal of Nephrology in 2020, which shows indications for initiation of renal replacement therapy in pediatric AKI are refractory electrolyte imbalance, refractory fluid load means more than 15% of weight gain, which is refractory to diuretics. Then refractory metabolic acidosis, complication of uremia, and progressive severe dysnatremia, and malignant hyperthermia, oligouria, to create space for nutrition in oligouric patient, endogenous toxins and exogenous toxins, and last is IEM, especially hyperammonemia. Recently, IAP treatment guideline for AKI also give indications for renal replacement therapy. According to them, fluid overload is the most common indication for initiation of dialysis in AKI and is the most important risk factor for poor prognosis in these patients. Others are same: metabolic acidosis, hyperkalemia, hypernatremia, which is symptomatic. And if urea level is more than 160, then when space is needed for more fluids, like blood is needed or drugs or some nutrition, sometimes dialysis is needed. And then dialyzable toxins, which may be endogenous or exogenous. Dialysis modalities available are PD, hemodialysis, and continuous renal replacement therapy. Which is better? So it totally depends upon the clinical condition and availability of resources. Peritoneal dialysis is a good option in hemodynamically unstable patients who have coagulopathy or difficult access and under-resourced setting. It is simple to do, no anticoagulation needed, hemodynamical stability is there, and cost is also low. But toxin removal is not good with this method. And second is protein loss is high with this method, and peritonitis risk is always there. Then another modality is intermittent hemodialysis. It can be done in hemodynamically stable patient. It removes toxins rapidly, but also anticoagulant exposure is less, but continuous, cost is also low than continuous renal replacement therapy for more than PD. But problem is that it can cause hypotension and dialysis disequilibrium because of rapid fluid loss. Next method is continuous renal replacement therapy, which can be done in hemodynamically unstable patients. It provides continuous removal of toxin. Hemodynamic stability is better, but cost is very high. It doesn't increase the risk of intracranial pressure, and it easily controls fluid balance. But anticoagulation need is more, patient immobilization is needed, and comparative slower removal of toxins are the problem with this method. So according to clinical picture and availability and expertise in the setup, this can be decided. Chronic kidney disease. Prevalence of CKD in pediatric population is 18 cases per million children. And since last few decades, prognosis is gradually improved with better treatment option and monitoring and treatment facilities available. Mortality rate is very high in comparison to peer group, around 30-fold. Most common cause of CKD and end-stage renal disease in infant and children is congenital anomalies. of urinary tract, while in older children, glomerular diseases are more common causes. So, key question for this topic talk is when to initiate. This question is mostly for the chronic dialysis, which is needed in chronic kidney disease patients, especially with end-stage renal disease. So, it is difficult to say when to initiate dialysis. We have to analyze. Risk-benefit analysis is very important. What are the benefits of dialysis? Symptoms and signs will improve, growth and development will better, and nutrition will be maintained. What are the risks? Just like blood transfusion, it has its own complications. So judicious decision is very important. And second important factor is to change the way of life, not only of child, but caregiver. Both are affected a lot. There are many social issues, psychosocial issues, economical issues. So everything have to be counted, and then we have to consider when to initiate dialysis. So what is the controversy in this eGFR based decision, early or late? It is the major issue which was discussed, and in literature it is published already. Many studies are published where some advocate early hemodialysis while some advocate late dialysis, basically in adult population. One important study was done where that is the ideal study that was done in adult population from 2006 to 2008 to 2008, and published in 2010 in New England Journal by Dr. Cooper. And according to this study, late initiator or early initiator, there is no significant difference between mortality, or there is no significant difference between adverse reaction. So their conclusion is that in early starter, there is no significant decreased risk in mortality, or there is no other effect of adverse reaction. So it is better to, but that is their conclusion. So after that, late initiation of dialysis was also considered. Many countries have different guidelines for indication, eGFR based indication to start dialysis. In pediatric population, no randomized control study like this study. But some retrospective cohort studies were published, especially in 2019, one by Dr. Preka. They used ESPN registry for children, and around 2,900 children they included in the study, and they found that hypertension is increased in late starter. Otherwise, no significant difference in growth, mortality, or any other complication. Median eGFR in their study was 8.2. Second study by Okuda, which et al., who used US Renal Data System Registry, and around 9,900 cases they include in their study. It is again heart study, and they found that mortality increase in children who start dialysis at higher eGFR. So higher eGFR they consider more than 10, and lower eGFR less than 10. But they include 4 groups: less than 5, 5 to 7, 7 to 10, and more than 10. And they found in below 5 eGFR, mortality is less, and above 12 eGFR, mortality is comparative high. Their median eGFR was 7.8. Winnicki is study by Winnicki is also published in same year, and they use include 2 groups. One is eGFR below 10, and one is above 10. And they found mortality rate is high in late starter, I think here. Next, so what are the indications for dialysis in CKD? As per Nelson textbook of pediatrics, we should plan stage 4, the dialysis in stage 4 CKD when GFR is less than 30 ml per minute, 1.73 meters square. Starting or initiation of initiation of dialysis can be decided based on eGFR, which is around 10 to 15 ml per minute, 1.73 meters square. On high eGFR, dialysis can be started in case of diuretic resistant fluid overload, severe fluid restriction, uncontrolled electrolyte abnormalities, and uremia. So what is the goal to start dialysis? First, to improve quality of life. Second, growth and development should be optimum. And third, malnutrition, severe fluid and electrolyte abnormalities should be prevented. So second important issue is how to decide modality, which modality is better. KDIGO in 2018, one conference was held by KDIGO in which they discussed many issues regarding to CKD management, and they found that residual kidney function was, and their executive conclusion was published in Kidney International in July 2019. And they reported that residual kidney function was not the sole consideration in selecting the initial dialysis modality. Because quality of evidences are not strong, these are mostly small observational studies and single-centered study mostly. And second, they found that available data are not enough to suggest one modality is favored over another. Their suggestion, their advice in this conclusion was that one size fits all approach should be changed to more individualized care approach. But basically this for adult patients. Selection of dialysis mode, how we will decide? First, age is very important factor. In mostly all over the world, below 5 years, peritoneal dialysis is the most used dialysis method, and above 13 years of age, in 50% cases, hemodialysis is used. Second place where dialysis is planned, so it is a remote area or a low resource settings or underdeveloped countries. What equipments are available, what is the level of caregiver, how much care he can provide, what is the home setting of that patient. These all are the important parameters to decide which dialysis mode is better. So no evidence suggesting one mode of renal replacement therapy is superior to another method. So hemodialysis or peritoneal dialysis, depending upon all these factors, a patient can travel to dialysis center 2 to 3 times a week with caregiver 4 to 6 times. Second, if a dialysis unit is available there, experts are available, healthcare workers are trained in caring of these patients, and then equipments are available there, then we can think about hemodialysis. Otherwise, peritoneal dialysis is a better method which can easily done at home. And if caregiver advising peritoneal dialysis, again caregiver is a very important factor. In KDIGO conclusions, one important point they mention about pediatric dialysis is kidney failure risk equation score. They wrote about a study which is a retrospective cohort study of 603 children in which EGFR less than 60. They used this KFRE score, and they found that within 1 to 2 years, risk of developing end-stage kidney disease is at least they compare both the scores less than 13.2 and more than 13.2, and they found a significant difference. And they advise that such type of scores can be tried to decide in which child end-stage kidney disease develop in next few years, and according to that, dialysis decision can be taken. Second, they advise randomized control trials should be done in pediatric population, because without it, it is difficult to say what is the clear, difficult to say when we should start that dialysis. Now newborns. Newborn is also a very separate entity. Their indications are different, their age and their weight is different, and equipments needed are totally availability is also a big issue for these children. Sepsis is the most common cause of AKI in the children, around 32%, followed by hypovolemia around 18%. Congenital anomaly of urinary tract, CHF and birth asphyxia, each around 11 to 12%, responsible for 11 to 12% of cases of AKI. So what is the indications to start dialysis? So AIMS guidelines suggest when conservative management fail, then we can decide about dialysis. Indications are refractory severe fluid overload, refractory hyperkalemia, metabolic acidosis, uremia, and if inadequate nutrition due to severe fluid restriction, then again dialysis should be think about. Then dialysis in neonate, again, what are the issues, modalities, peritoneal dialysis versus hemodialysis. Till recent past, hemodialysis is not feasible in newborns or small infants, but now up to 3 kg of children, hemodialysis can be done equipments are available. In India, equipments are also available, but below 3 kg, especially in newborns, we cannot use hemodialysis. Peritoneal dialysis is a feasible option in these newborns, like catheter, stiff versus soft. If dialysis needed for less than 48 to 72 hours, then stiff catheter can be used. Otherwise, it increases the risk of injury. So soft Tencox catheter is a better choice for more than 48 to 72 hours dialysis if needed. But in below 1 kg child, soft Tencox catheter cannot be used. So stiff catheter or some other stiff cannula can be used for dialysis in these children. Continuous renal replacement therapy, till recent past, there was availability of equipments and other material was not there. But now in India, above 4 kg of child, continuous renal replacement therapy is available, I think, in some metros. But in peripheries and low resource setting, I don't think continuous renal replacement therapy is available. So best method for dialysis below 5 years of age, below 10 kg of weight is peritoneal dialysis. Although in some centers, hemodialysis facility is available, but especially in newborn, PD is the best option. What is the take-home message? Dialysis initiation decisions should be patient-centered. eGFR and clinical features both should be used to decide dialysis initiation. The optimum time to initiate dialysis and mode of renal replacement therapy should be decided case-to-case basis. Thank you.
I request Chairperson to kindly comment.
Hello. Am I audible?
Yes, ma'am.
Am I audible?
Yes, ma'am.
Yes,
Yes,
ma'am.
ma'am.
Yeah. So congratulations, ma'am, before my co-chairs take over. So from my comments, excellent talk. I mean, you have given a wonderful bird's eye view of the problems encountered in pediatrics, the causes of pediatric ESKD as well, and the challenges faced during dialysis. So in our unit, actually, we have a hybrid sort of a unit. Ours is the only unit in the government sector where we have an affiliated pediatric hospital, and 40% of our admissions in pediatric, in the nephrology unit are pediatrics. So we cater to newborns, infants, and really it's a big challenge, and it's much more difficult than taking care of the adults. So are you aware of any centers in India which have Carpedium machines and which have Nidus machine? Have you any experience using those machines?
Ma'am, I'm basically pediatrician. I'm not nephrologist, and I'm only reading these machines about AIMS PIC protocol only. So recently I read about all those things.
No, madam. So far there are no machines available.
Okay.
Even in Medanta, Dr. Siddharth Sethi has discussed a lot about it, but there are so far no machines available because of the various other issues.
Okay, so the majority of dialysis you are doing in pediatrics is peritoneal dialysis, or a lot of the patients now are on hemodialysis in your unit? How is it there?
At our center, madam?
Yeah.
So, madam, for all the newborns, peritoneal dialysis is the only option at present. Though we have tried CRRT in one of the inborn error of metabolism child, where ammonia levels were very high and needed CRRT. But for the rest of the newborns, we do peritoneal dialysis. In pediatric patients, yes, we do for both AKI and CKD. Even in 7-8 kgs, we do hemodialysis, which is like because of the now 6.5 French catheter available, and FX5 is also available. So for that we can do it at our center, but it is very difficult in periphery.
Yeah. Okay. So that's what for us also. Basically, majority of dialysis is like peritoneal dialysis, though now around, as you said, around 8 kgs, 7-8 kgs, we are able to take them for hemodialysis as well. So yeah, so thank you, congratulations. And I think pediatric nephrology is gaining a wide attention now, and it's coming up as a super specialty in itself, and time is not far off when pediatric nephrology would be entirely catering to all the kidney diseases in children. As of now, some of the load is taken by the adult nephrologist, but I see that the day is not far off and you people are really doing a wonderful job. And in fact, I think in all the conferences, there should be a session on pediatric nephrology, because in peripheries where the pediatric nephrologist is not there, the adult nephrologist should also have a little bit training, because otherwise they are scared to touch the newborns, and I mean, leave alone the newborns, even the children they're not comfortable with. So the adult nephrologists also have a lot to learn from the pediatric nephrologist, especially patients in dealing with children. Thank you. That was an excellent talk. And over to my co-chairs for their comments.
Thank you so much, madam. Thank you so much for your kind words about pediatric nephrology. Dr. Premila, it was an excellent lecture. Though being a pediatrician, you have touched upon many areas which are not discussed so far. If we talk about AKI in pediatrics, then nowadays the guidelines and the evidence is coming up that the earlier initiation of dialysis is more helpful rather than to wait and to have more fluid overload and to have more electrolyte imbalance. And yes, for the even for various metro cities, still peritoneal dialysis is preferred method in AKI in children and newborn. But I would say that the peritoneal dialysis, though such a simple procedure, it is not very well taught to pediatricians, and even availability of pediatric nephrologists is very difficult. If we talk about CKD, then as you discussed that not only on the basis of GFR, but rather overall picture, whether because we, generally at our center, what we do is when the GFR comes to less than 15, we start preparing them for kidney replacement therapy. But from 15 to 10, we don't know where when child will drop from 15 to 10. It may take 2 months, 6 months, depending on the native kidney disease, or it may go up to 1 or 2 years also. So yes, we do prepare them, do counsel them, and we try to make fistulas if possible. We are very fortunate enough to have very good surgeons. They are making fistulas even in 12 and 13 kg of the kids. And so we do try fistulas, and then we prepare properly, and then we initiate when the other issues like hypertension is not controlled, some amount of fluid overload is there, or hyperkalemia is there, acidosis is not managed. And then we initiate after a thorough counseling of the full family, because all the social stigma in pediatrics is way more than in adults. So it is there. And if we talk about very low birth weight babies, less than 1 kg, even the stiff PD is very difficult in AKI. So there are other ways, options like you can put ICD, or you can put soft PD catheter. Many a times we have also put HD catheter for doing peritoneal dialysis from the lateral rectus wall, and we puncture to the not in the midline, and we puncture through lateral rectus wall, and then we do PD via that catheter. So it is it needs a lot of modifications, but yes, we can do even in very low birth weight babies also. Yeah, it was wonderful lecture, and you have touched upon almost all the possible issues. Thanks a lot. Thank you so much, organizers.
Thank you. Thank you, organizers. Any questions? I think pediatric nephrologist and nephrologist will better answer if any questions are there.
Thank you, ma'am. Thank you, chairpersons. Thank you for explaining pediatricians' perspective on dialysis initiation in children. So far, we have not received any questions in chat. So moving on to penultimate session. The topic for the session is cardiovascular issues in CKD population by Dr. Ronak Bhandari, sir. I now invite Dr. Manish Jain, sir, Senior Consultant Nephrologist, Apollo Hospital, Kolkata. And due to unforeseen medical emergencies, Dr. Sarita Rao ma'am and Anirudh Vyas sir could not join us. I also invite Dr. Jai Singh Arora sir, Consultant Nephrologist, Transplant Physician, Indore, to chair. Over to you, chairpersons. I request you to briefly introduce speaker. Thank you.
Good evening, everyone. So it's always a pleasure to introduce a dear colleague and dear friend, Dr. Ronak Bhandari, who is a DM cardiologist from Jayadeva Institute. So he'll be discussing on cardiovascular complications in CKD. And definitely the heart matters, both in the disease and otherwise. So I'll invite Dr. Ronak Bhandari to continue the talk.
Hello, yeah, am I audible?
Yes, sir, you're audible.
Yeah, thank you. Thanks, Dr. Jay. It's always a pleasure to speak whenever you call me here. So the topic for my talk today is cardiovascular complications in CKD, and my slide is not running once again.
So slide is visible.
Yeah, no, but it is not going forward yet. It's stuck there. Once again, I'll stop sharing and then again start it.
Yes, yes, sir, yes, sir. Thank you.
Yeah, so my talk will be divided into the following subheadings. I'll start with the epidemiology and prognosis of cardiovascular complications in CKD. So as you know, CV cardiovascular events are very common in chronic kidney disease patients. Nearly 50% of all patients with end-stage CKD stage 5 to 4 have cardiovascular complications. And cardiovascular mortality accounts for 40 to 50% of all deaths in patients with advanced CKD as well as end-stage renal disease. This compared to 25% in patients with normal renal function. So it is a very substantial burden of mortality of renal patients, which goes to cardiovascular too. Now this graph compares the cardiovascular risk by age in the general population and in renal transplant and hemodialysis patients. As you can see, in the initial years, a patient with in the younger age group, there is a 500 to 1,000 times increased cardiovascular mortality for a young patient who is already in hemodialysis compared to a normal person. And the risk is similar to a mortality of a 85-year-old normal age group patient. Now coming to the CV risk, according to the stages of CKD, the cardiovascular risk increases as the stages of CKD progresses. And in end-stage renal disease, it is approximately 20 to 1,000 times the CV risk. So there is increasing evidence indicating a relationship between albuminuria and cardiorenal risk. And albuminuria is considered to be a prognostic marker for cardiovascular risk. High levels of albuminuria indicate an increased risk of mortality independent of eGFR. The risk of developing cardiovascular disease in CKD surpasses the risk of reaching end-stage renal disease. Therefore, CKD must be considered to be one of the strongest risk factors for development of cardiovascular disease. Coming to the pathophysiology of cardiovascular disease in CKD, as you know, CKD is a chronic pro-inflammatory state which contributes to both vascular and myocardial remodeling, and which in turn leads to atherosclerotic lesions, vascular as well as valvular calcifications, myocardial fibrosis, and even calcification of cardiac valves. So in this respect, CKD mimics an accelerated aging of the cardiovascular system. This is a diagram depicting the relationship between cardiovascular system and chronic kidney disease. The common risk factors are common like age, diabetes, environmental factors, and then hypertension, inflammation, calcification, uremic toxins, and coagulation, and all lead to progression of cardiovascular disease as well as arrhythmias and heart failure. In addition to the hemodynamic mechanisms, various other mechanisms also contribute to progression of cardiovascular disease in CKD, like neurohormonal activation, activation of sympathetic and RAS systems, chronic inflammation, malnutrition, endothelial dysfunction, hyperphosphatemia leading to LVH and cardiac remodeling, then valvular and vascular calcification, uremic toxins may also contribute to cardiac fibrosis. So these are again a summary of the risk factors for cardiovascular disease in CKD. There are some traditional, which can be divided into either traditional or non-traditional or novel and uremia-related risk factors. Traditional risk factors like age, male sex, hypertension, smoking, hypertrophy, left ventricular hypertrophy, diabetes, dyslipidemia. These non-traditional risk factors are all related to uremia, which like sympathetic activation, hypothyroidism, uremic bone disease, protein energy fasting, oxidative stress, increased inflammation, endothelial dysfunction, anemia, vascular calcification. I will now elaborate these risk factors one by one. Coming to the traditional risk factors, these are highly prevalent in CKD patients, and they contribute to both atherosclerotic cardiovascular as well as cerebrovascular disease and lead to CKD progression because of their effect on both large vessels and smaller vessels. And these effects may also contribute to the recently described association of CKD with abdominal aortic aneurysms. Coming to hypertension, it is highly prevalent in CKD, approximately 90%. It is a major risk factor for CAD, LVH, and increased mortality. Good control in CKD stages 1 to 4 may be associated with possible benefits for cardiovascular disease. But once on dialysis, the relationship with outcomes is less clear. And patients with comorbid disease may have low blood pressure, thereby reflecting underlying cardiac dysfunction or cardiomyopathy. Now, the circadian rhythm of BP in CKD. Normally, there is a nocturnal fall in blood pressure, which characterizes a normal circadian dip. In those patients where this nocturnal dip does not happen, that is suggestive of a bad prognosis, and that is associated with severity of interstitial fibrosis and tubular atrophy in kidneys. So dipping patterns are blunted in CKD and is relevant for management of hypertension in CKD. Coming to the management of hypertension in CKD, lifestyle modification is very important to maintain a healthy BMI, lower salt intake, exercise programs, limiting alcohol intake. Now, ACE inhibitors or ARBs are first-line therapies in diabetic and non-diabetic CKD population, and with proteinuria more than 30 mg per 24 hours. Individualizing the BP targets as well as agents, and to inquire about postural dizziness and check for postural hypertension. Coming to a very important association of CKD with CVD, that is heart failure and hypertrophy. They develop early in CKD and increases with progression. 75% of these patients will have some form of LVH at the time of dialysis initiation. It is a strong predictor of both morbidity and mortality. Hypertension and calcific valvular disease, which will lead to LVH, which in turn will lead to pressure overload, and that in turn will lead to heart failure. High ultrafiltration rates are associated with higher mortality despite treatment of congestion. So rapid fluid removal acutely reduces the extracellular volume and causes transient myocardial ischemia and myocardial stunning. Coming to the management of heart failure in CKD, first-line therapies, beta blockers are recommended as the first-line therapy in patients with heart failure and EF less than 50%. Along with it, mineralocorticoid receptor antagonist is recommended if it is not controlled with ACE inhibitors or beta blockers. Spironolactone and eplerenone are the two important MRAs which have improved the prognosis in patients with heart failure and CKD stages 1 to 3. Now, diuretics are indicated in NYSA 2 stage with fluid retention and in NYSA 3 to 4 to reduce the risk of decompensation, but no prognostic benefit on mortality seen. For patients who are on combination therapy with ACE inhibitors, beta blockers, and MRAs, but who continue to be symptomatic, administration of a ARNI is also recommended. ARNI is a boon in cardiovascular heart failure. So it can also be used in CKD patients stage 3 to 5, combination of sacubitril and valsartan, which is associated with a reduction in overall mortality, both cardiovascular as well as renal mortality. Coming to diabetes, hyperglycemia is strongly associated with the development of CVD as well as CKD, but improvement in sugar control in type 2 diabetics mainly contributes to a reduction in microvascular events such as nephropathy, but it does not affect the macrovascular complications as such. So data from the large cardiovascular outcome trials with SGLT2 inhibitors or GLP-1 receptor agonists have shown a significant reduction in cardiovascular events in type 2 diabetics. So these two agents should be used or can be used in CKD population as well. Coming to dyslipidemia, the common lipid abnormalities in CKD population is elevated triglyceride, a low HDL level, and mostly normal LDL cholesterol level. The factors which modify the composition of HDL in CKD include various uremic toxins, increased oxidative stress, and a pro-inflammatory microenvironment. These factors will contribute to a remodeling of HDL particles, altering its composition and inducing post-translational modification of the HDL protein cargo. Further accumulation of various uremic toxins like symmetrical dimethylarginine in advancing CKD also plays a role in the modification of HDL particle, and thereby it makes it more atherogenic. So it is a table summarizing the various lipid abnormalities in renal disease. CKD will have a low HDL and LDL will remain same, but triglycerides may rise and will rise. Management of dyslipidemia, the two studies 4D and the Aurora trial failed to show significant reduction of cardiovascular death, non-fatal MI, non-fatal stroke by both atorvastatin or rosuvastatin compared to various placebo in patients on hemodialysis. And these data suggest that the cardiovascular benefit of lipid-lowering therapy is attenuated in subjects with low GFR and is mainly absent in patients with end-stage renal disease on hemodialysis. Coming to another risk factor or a complication of cardiovascular complication in CKD is cardiac arrhythmia and sudden cardiac death. Nearly half of 50% of cardiovascular mortality in ESRD patients may be related to a form of arrhythmia. CKD patients are more prone to arrhythmia due to many risk factors like electrolyte abnormalities and their shifts with hemodialysis, high rates of CAD, hypertension, heart failure, rapid changes in blood pressure or volume in the intra as well as interdialytic periods. The sudden cardiac arrest is associated with low potassium dialysate level, low pre-dialysis serum potassium, increased ultrafiltration volumes leading to rapid volume shifts and leading to hypotension as well as low calcium dialysate. A word about atrial fibrillation in CKD. AF is very common in dialysis patients with a prevalence of around 10%. It is even more common, but undiagnosed 40% of ESRD without known AF at baseline had AF detected with an implantable loop recorder. So the AHA-ACC guidelines for management of AF recommends warfarin for dialysis patients with STAT score more than 1. And routine anticoagulation of all dialysis patients with AF cannot be recommended unequivocally at present. Coming to sudden cardiac death in CKD, it is very important since more than two-thirds of mortality in advanced CKD stages are a result of sudden cardiac death, which is mainly caused by ventricular arrhythmias. Dialysis itself is a risk factor for sudden cardiac death, with the highest risk of sudden cardiac death within the first 12 hours after dialysis or after a long dialysis-free interval. So accordingly, the patients with peritoneal dialysis, they seem to exhibit a low risk of sudden cardiac death. So coming to the prevention of sudden cardiac death and arrhythmias in CKD, the rate of sudden cardiac death is very high compared to the incidence of coronary heart disease in CKD, and even a complete revascularization can only partially reduce the risk of cardiac death in patients with CKD. So the pathophysiology of sudden cardiac death in CKD patients is different to that of a normal patient. ICD patients with CKD will exhibit an increased mortality, and therefore value of ICD implantation in this group has been questioned. And despite the small number of dialysis patients in clinical studies, current guidelines recommend a primary prophylactic ICD if the EF is less than 35%. Coming to acute coronary syndrome in CKD, nearly 17 to 18% of deaths in ESRDs are attributable to a ACS. 60% of new hemodialysis patients may have evidence of coronary atherosclerosis. Systemic persistent inflammation is the main risk factor in ESRD, and vasoconstriction may also play a very important role. Now, symptomatic angina may occur with normal coronary due to subendocardial ischemia or in the presence of LVH due to the capillary myocyte mismatch and microvascular dysfunction. Non-ST elevation MI is the most common type of acute coronary syndrome in this subtype of patients. It is challenging to diagnose ACS in CKD population because of two things. Chest pain may be absent in more than 50% of these patients due to autonomic and neuropathy, and troponin values may be problematic. Patients may have elevated troponin due to CKD itself in the absence of any clinical ischemia. Nevertheless, if the troponin is elevated with a dynamic increase in troponin occurs of more than 20% within 9 hours and at least one value exceeding the 99th percentile, it may be diagnostic of ACS. But a high index of suspicion is necessary to avoid missing the diagnosis. Regular assessment of cardiac function with NT-proBNP and ECG at initiation of dialysis initiation, and then annually. Echo is recommended in all dialysis patients after they achieve a dry weight, and preferably 1 to 3 months after initiation, and at 3 years interval. Cardiac MRI is not feasible economically in all patients. 3-day echo demonstrates an accuracy quite close to MRI. Coming to the management of CAD in coronary artery disease in CKD patients, to prescribe secondary preventive treatment in all CKD patients who experience an atherosclerotic event, there is no evidence to suggest primary prevention with aspirin or clopidogrel in CKD population. Avoid therapeutic nihilism, that is under treatment of CKD following myocardial infarction or coronary revascularization. Hyperphosphatemia and elevated parathormone are also associated with increased mortality. The ischemia CKD trial was a landmark study which assessed an invasive versus conservative approach in patients with stable CAD and CKD. And this trial showed there was differences in the primary composite endpoint of death or non-fatal MI in patients who underwent invasive approach compared to the conservative approach. But the invasive strategy was associated with significantly higher incidence of stroke and death or initiation of dialysis. So coming to the issue of percutaneous coronary intervention in CKD population, it can be done, but should be done in the right patient with the use of either ultra low contrast PCI or zero contrast PCI. Patient should be adequately hydrated, and imaging guided PCI may also help in this population. This is a flowchart of ultra low contrast PCI and how to go about it. I think I'll skip this. Now coming to the non-traditional risk factors, these are some, as I already told, oxidative stress, endothelial dysfunction, protein carbamylation, uremic toxins, CKD with mineral and bone disease, and gut dysbiosis. Vascular calcification, the vascular smooth muscle cells are the main components. They basically switch their phenotype from a contractile to a more synthetic phenotype in CKD population because of the hemodynamic changes, and the resulting cardiovascular calcifications are markedly accelerated in this population. And the histological prevalence of vascular calcification in radial arteries was found to be 45 times higher in patients with CKD. So this is a diagram depicting the conversion of the mesenchymal VNCs under stress or in patients with CKD because of inflammation and other factors. They become synthetic and they start synthesizing. They become synthesizing calcific. They become calcified and that turn the vessels into more calcium, like calcium deposition in the vessels. The calcification of the central arterial vessels will contribute to increased cardiac afterload and thereby to heart failure. The resulting hemodynamic alteration induces LVH associated with decrease in coronary perfusion. A particularly severe form of vascular calcification is the uremic calcific arteriopathy, also known as calciphylaxis, that is caused by calcium deposition in the media of the dermo-hypodermic arterioles, leading to skin necrosis and carries a high mortality rate. Exact mechanism of this is unclear. There are some CT images of various calcifications in various organs of the body in CKD patients, in the heart, in the femoral arteries, in the brain, even in the skin. The uremic calcific arteriopathy can be seen in this. Coming to valvular calcification, calcification of cardiac valves, in particular the aortic valve, is a frequent cause of valvular stenosis, which may require intervention. Depleting patients with vitamin K can retard the progression of valvular calcification in this population. Electrolyte imbalances like dysmagnesemia are common in CKD, and they contribute to a poor patient outcome and are potential targets for managing coronary artery calcification. In particular, magnesium, frequently reduced in CKD, has gained interest because of its inhibitory effect on vascular calcification. Because magnesium interferes with the hydroxyapatite crystal formation and thereby can halt vascular calcification in CKD. In aortic valve disease, in-hospital mortality for AVR rises up to 21% in CKD stage 5. TAVI is recommended as a safe and effective effective option in patients less than 75 years old at elevated operative risk. For patients with the elevated operative risk for a surgical AVR, an acute kidney injury after TAVI was less prevalent than with SAVR. Coming to mitral valve disease in CKD is associated with adverse outcomes in any intervention of the mitral valve, mortality increasing with the increasing stage of CKD. Surgical treatment of mitral valve incompetence with valve reconstruction, that is MitraClip, is superior to valve replacement. Now, inflammation is a very good process, as already I have described previously. It is a systemic inflammatory disease, CKD. So pro-inflammatory mediators are increased because of various oxidative stress caused by the accumulation of advanced glycogen end products, metabolic acidosis, reduced clearance of cytokines, and the post-translational modifications of lipoproteins and epigenetic factors. So a landmark study, the CANTOS trial, which was done in 10,000 stable post-MI patients with elevated hsCRP levels. This trial demonstrated a benefit of the monoclonal antibody canakinumab was able to inhibit the pro-inflammatory effector IL-1 beta, and this effect was larger in patients with eGFR less than 60. So this is not yet in guidelines, but can come up in the future for CKD population. Association of uremic toxins with CVD. Two important uremic toxins, p-cresol and indoxyl sulfate, both inhibit nitric oxide production, and ultimately they trigger the pro-inflammatory cascade and lead to vascular damage and lead to vascular calcification and various types of cardiovascular complications. Coming to the various uremic reactive oxygen species, again because of inherent CKD or loss of antioxidants during dialysis, malnutrition, bacterial products and dialysate, all will lead to elevated oxidative stress, and that will lead to increased pro-inflammatory pro-inflammatory state, and again, progression of cardiovascular disease. Uremia itself is a pro-oxidant condition. Again, this is a diagram depicting the association of the uremic milieu and the increased pro-inflammatory cytokines leading to damage to the various organs of the body. In particular, increased endothelial dysfunction, increased smooth muscle cell proliferation in the vessels that will lead to various types of cardiovascular complications. Now, protein carbamylation, irreversible protein carbamylation results from interaction between amino acid glucoproteins and isocyanuric acid. This is increased by chronically high levels of urea in CKD population. This was also linked to an increased cardiovascular risk. Protein carbamylation alters the structure of LDL that will lead to increased atherosclerosis, albumin, renal fibrosis, and erythropoietin anemia. So intensification of hemodialysis therapy helps in controlling low levels of plasmouria and reducing carbamylation of the protein. Coming to the novel therapies of cardiovascular disease in CKD, as I've already discussed, SGLT2 inhibitors, they lead to significant reduction in the primary endpoints of eGFR decline, renal or cardiovascular death, heart failure hospitalization, and a reduction in all-cause mortality. A new agent, the new selective non-steroidal MRA, Finrenone, it also blocks the damaging effects of aldosterone. In contrast with the conventional MRAs, Finrenone is equally distributed in both myocardial and kidney tissues. So it reduces cardiovascular morbidity as well as mortality and prevents progression of renal disease, according to the Fidelio and Figaro trials. So coming to the conclusion of my talk, in patients with CKD with cardiovascular disease as well, you should encourage lifestyle modification. You have to detect before it is too late. Don't undertreat both CKD in CVD and CVD in CKD. Consider treatment complications and be aware of any paradoxical observations like low LDL, hypertension, or low BMI, especially in the late stages. Thank you.
Dr. Manish Jain, if you want to start with.
Thank you, Mr. Bhandari, for this nice deliberation. Cardiovascular complication is a very important part of the cardiac disease responsible for the morbidity and mortality. And this required a multifactorial approach, including the lifestyle medications, improvement, dialysis, and many times transplantation. This is a very lecture include all the things cardiovascular as well as the renal part. Thank you, Dr. Bhandari, for this nice presentation.
Thank you, sir. Thanks.
Okay, so I would not be taking much time between the most exciting part, which is coming the MCQ and the quiz part. The preparation has already started. Definitely the takeaway point for me was specifically the therapeutic nihilism. I think it is not only among the patient attendants, but also among the clinician, including cardiologist and nephrologist. I think contrast-induced nephropathy is very much overrated, and other parameters when we don't are able to optimize in CKD patients because of some of the other reasons, then we defer the therapeutic modalities also in cardiology. So I think the future is very bright for nephrology, specifically with coming up of so many newer therapeutics. And with this, I think it was a fantastic session by Dr. Ronak, and all the parts of heart and nephrology was covered. So we can proceed with the last session, the most excited and most awaited. We will, I think this session can be concluded. Over to the host.
Thank you, sir. Thank you, Dr. Ronak Bhandari, sir, and chairpersons for discussing on various implications of cardiovascular disease in CKD. Moving on to final and interesting session, postgraduate quiz for medicine and pediatric residents. I now invite Dr. Megha Saigal, ma'am, Assistant Professor Nephrology, AIIMS, Patna. And the session will be presided over by Dr. Vatsala Patel, ma'am, Consultant Nephrologist, Surat, Gujarat. Over to Dr. Megha Saigal, ma'am.
Hello, everyone. Am I audible?
Yes, ma'am, you're audible.
Okay, so very good evening to all the people present here. And special thanks to Win India and Central Zone for letting me be a part of this World Kidney Day celebrations. So I will be starting the quiz since we have very less number of participants. So I will encourage everyone, whether it's the panelists or whoever is participating, to share their answers, and they can just type their answers in the chat box. It will be like a fastest finger first. So you'll get a 10-second time when I will start the question, and then after I'll give a 10-second break. Whoever gives the correct answer first, I will be selecting him. So after the end of the quiz, we will see who was the one person who gave the maximum number of correct answers in the shortest time possible. So I hope the rules are clear to everyone. You can answer in the chat specifically to me in your chat box. The prize will be decided by the Win India Central Zone. You can ask the secretary, Dr. Isha Tiwari Arora, to discuss regarding the prize. So you can, I will be starting the quiz now. Please answer your questions in the chat box, okay? So the first question is my slides moving? Yeah.
Yes.
The first World Kidney Day was observed in which year? A, 2001, B, 2006, C, 2010, and D, 2015. Your 10 seconds start now. Okay. Okay, so the next, the answer to this is so the answer to this obviously has been discussed by Dr. Isha in her slides. Yeah. World Kidney Day was started in 2006 and has not stopped growing ever since. Every year, the campaign highlights a particular theme. So already we have discussed the World Kidney Day theme for 2023. I would like to go back a year and ask you, what was the world theme for World Kidney Day 2022? Was it kidney disease and children? Was act early to prevent it, donate kidney days for life, kidney health for all, bridge the gap for better kidney care, and or protect your kidneys, control diabetes? Okay. Okay, so coming back for the answer. I'm sorry. Yeah. So the Kidney Health for All was on 10th March last year, and the theme was Bridge the Knowledge Gap for Better Kidney Care. Okay, so the third question is, the International Society of Nephrology is headquartered at A, Edinburgh, Scotland, B, Bern, Switzerland, C, Boston, USA, and D, Brussels, Belgium. Okay. So the answer is the ISN announced the establishment of global headquarters in Brussels, Belgium. Okay, so the next question is, this is a very simple question. Most common cause of end-stage kidney disease worldwide is chronic glomerulonephritis, diabetes mellitus, tropical infections, or systemic hypertension. Okay. So the answer for this is diabetes mellitus. So as you can see, diabetes is the most common cause of end-stage kidney disease. It leads by 44%, followed by hypertension, then glomerulonephritis, then polycystic kidney disease, and 20% as other or unknown. The next question is, which place in India is famous for a form of endemic nephropathy? A. Bhuj, Gujarat, B. Bhatinda, Punjab, C. Srikakulam, Andhra Pradesh, D. Pondicherry, Tamil Nadu. Okay. So, as you know, Uddanam was the answer. Uddanam is a lush green district with rich in coconut and cashew plantations in a Srikakulam district of Andhra Pradesh, India. An unknown number of people living in this area have a chronic kidney disease of unknown etiology, a disease that mostly affects the farmer and the agricultural workers. And this condition was discussed and named Uddanam nephropathy at the 2013 International Congress of Nephrology held in Hong Kong, China. Okay. So after this, the next question. This is the DMSA scan of the kidneys. Identify the abnormality in the picture. A, sigmoid kidney, B, horseshoe kidney, C, duplex kidney, and D, malrotated kidney. Okay, so this was the horseshoe kidney, which is a congenital abnormality wherein the lower pole of both the kidneys are fused together across the midline. Okay, the next question is, which of these is a bone-derived hormone and plays an important role in the phosphorus homeostasis? A, osteocalcin, B, osteoprotogerin, C, fibroblast growth factor 23, and D, bone-derived neurotrophic factor. Okay. So the answer is FGF23 is the bone-derived hormone. It's secreted by osteocytes, and it's the most important regulator of phosphorus homeostasis in CKD. So the next question, which is a very simple question. The normal mean annual decline in GFR with aging is 0.5 ml per minute per year, 1 ml per minute per year, 3 ml per minute per year, or 5 ml per minute per year. Okay, the answer is that peak GFR is attained by the age 30, and following which the annual mean decline is 1 ml per minute per year. Next question, which of the following is not a risk factor for developing CKD? Childhood obesity, previous episode of AKI, low birth weight, or Asian ancestry? Okay, so among the different ethnicities in the world, only African ancestry has been identified to be associated with an increased risk of kidney disease and not Asian ancestry. So the next question is the bedside formula that we use to calculate the GFR in adults, that is named as Schwartz formula, Schreyer's formula, Cockcroft-Gault formula, or Brenner formula. So the answer for this, I am sure everyone knows, is the CG formula or the Cockcroft-Gault formula, which is derived as 140 minus age into ideal weight. They were creatinine into 72, and for women, we multiplied by 0.85. The next question being, which of these drugs reduce intraglomerular pressure? Perindopril, benidipine, bumetanide, and iloprost. So the answer is perindopril, which is, as you know, an ACE inhibitor and ARB, which acts by reducing efferent arteriolar constriction and hence reducing the intraglomerular pressure. Then the next question being, asymmetric size kidneys are likely to be encountered in diabetes mellitus, renal artery stenosis, amyloidosis, or FSGS. So the answer to this is renal artery stenosis. So asymmetric kidneys are generally seen with renal artery stenosis, reflux nephropathy, any abnormal development, or can be also part of the renovascular disease. What is the most common cause of anemia resistant to EPO agents? Whether it is inadequate dialysis, iron deficiency, chronic inflammation, or hyperparathyroidism. So iron deficiency is the most common cause, and that is why before starting EPO therapy, we always tell the patients to get an iron profile done so that we can replace iron first before giving EPO therapy for the patients. Inheritance of risk allele in which gene confers the highest rate of kidney disease risk in Africans, whether it's APOL1, ApoE2, ApoE4, or NPHS1. So as we all know that West African population has a higher inheritance of G1, G2 alleles in APOL1, and this gives a higher several fold higher risk of having CKD. Initially, it was thought that this APOL1 gene actually protects these West African from trypanosomiasis, which is a sleeping sickness disease. And that is why they have a higher prevalence of this disease in their population. So this is the next question, which is a CKD patient is admitted in the hospital for correction of severe anemia. He has already received 2 PRBC transfusions, and then you can see his ECG. What is the next step? Whether you will send a cardiotroponin test, I give IV calcium gluconate, check his patellar jerk or respiratory rate, start calcium-free dialysate. So as you can see, the ECG was showing tall tented T waves, which suggests hyperkalemia. And if we have a hyperkalemia, first thing that we have to do is stabilize the cardiac membrane so that the patient doesn't go into arrhythmia. So we will give calcium gluconate first and then start the anti-hyperkalemic measures. Then the next question, majority of nephrons are formed in which trimester of pregnancy? A, equal development in each trimester. B, first trimester. C, second trimester. And D, third trimester. Uh, 60% of nephrons are actually formed in the last trimester, and that is why we have preterm and low birth weight babies who are there. They are supposed to be at a higher risk of developing CKD later in life. That is called the Brenner's hypothesis, because they have a lesser nephron dosing at their initiation. Then the next question, again related to the embryo. Kidneys are embryologically derived from paraxial mesoderm, intermediate mesoderm, somatic lateral plate mesoderm, or splanchnic mesoderm. So the answer is intermediate mesoderm. Then the next question being, what is the amount of plasma water filtered by kidneys in a day? Is it 80 to 120 liters, 120 to 180 liters, 150 to 200, or 200 to 300? So 120 to 180 liters is the correct answer. Then the next question being, what is the bulk of sodium reabsorption in PCT is by which luminal transporter? Whether it's NHE, that is sodium hydrogen exchange, SGLT1, SGLT2, or sodium potassium ATPase. So actually, even though we talk about this thing SGLT1 and SGLT2 most, then NHE3 is the specific transporter in the PCT for sodium specifically. Then the most common protein secreted in urine is albumin, uromodulin, urodilantin, or beta-2 microglobulin. So the answer is uromodulin. That is the another name for Tams-Horsfeld protein, which is the most abundant protein secreted in the urine. What are the novel biomarkers for AKI except? So which of these is not a novel biomarker for AKI? TIMP2, NGAL, KIM1, LKM1. So the answers are the first three are novel biomarkers, and LKM1, that is liver kidney microsomal 1, is actually not a marker for AKI. It is a marker for autoimmune hepatitis. Now coming to some pictures. So you can see this kidney, and you have to tell me this is the pathological organ specimen, and you have to tell me this lesion is most likely as a result of bladder neck obstruction, Clostridium sepsis, genetic anomaly, or multiple abscesses. So this is a genetic anomaly, most common being polycystic kidney disease. This is, as you know, we cannot have a session without showing some histopath slides. So this you can see is the glomeruli, and there is some abnormality. So the alteration that you can see, or this abnormality that you can see in the glomeruli, that is indicated of what? TB infection, E. coli bladder infection, inherited condition, or severe basement membrane damage. So this is due to, this is a crescent formation, and this is due to severe basement membrane damage. Crescents, as we know, are formed by infiltrating and proliferating immune local cells along with deposited fibrin, and they occur after disruption of a glomerular structure, which allows for cells, cytokines, and blood proteins to pass through the blood vessel wall into the Bowman space. And the glomerular crescents mostly have procoagulant factors, macrophages, T cells, fibroblasts, and parietal and visceral epithelial cells. Next question regarding this histopath, continuing histopath. The features present in this glomeruli is suggest that this person needs his blood sugar to be checked. He has an occult renal cell malignancy. He has a recent strep infection, or he should have his urine culture. So you can see this is the glomeruli. This is the abnormality. And what do you think this person should do next? So actually this was like a nodular glomerular sclerosis, and that was a KW lesion, and there was nodules of pink hyaline material formed. And this was suggesting that this patient is a long-standing diabetic. Then as you can see this another histology, this is the blood vessel in the kidney. So the etiology of this kidney lesion is mostly due to atherosclerosis, autoimmune reaction, hypertension, or septicemia. So the thickening of the renal arteriolar wall, that was due to hypertensive emergency. And especially if the systolic BP rises to more than 180 or diastolic BP rises to more than 120, that can cause, as you know, hypertensive urgency and an emergency, end organ damage, which is known as hyperplastic arteriosclerosis, or the onion skinning, as we can see in the picture, leading to tiny lumen. So this is the last slide of the day. This is the IF slide. And this is a glomerular IF pattern with IgG antibody, which is typical for A, PSGN, B, Goodpasture syndrome, C, both, D, neither. So you can see this is the IF pattern. This is IgG in the IF pattern. And you have to tell me what is this significant for. So this was the PSG and immunofluorescence, which was demonstrating a granular starry sky or lumpy bumpy appearance due to IgG, IgM, and C3. So before thanking, I would like to tell you the winner. The winner is Dr. Lavanya, followed by Dr. Jay, and a special mention to Dr. Vatsa, ma'am, and also a special mention to Dr. Ronak Bhandari. Even though he's not a nephrologist, he has also managed to get some questions right. So thank you, everyone. And I hope you enjoyed this quiz. Over to you, Lavanya.
Thank you, ma'am. It was an interesting session. Now I invite Dr. Isha Tiwari, madam, for concluding remarks for the session.
Yeah, thank you so much, everyone, for joining in tonight. Special mention to all the speakers, chairpersons who spared their time on a Sunday evening. People living with kidney disease truly deserve a dedicated day in the year to contemplate over how best we can mitigate their misery and sufferings. And this year's theme of promulgating preparedness for disasters and pandemic and calamities is for sure the need of the hour. I would extend my heartfelt gratitude to the Win India National Committee for guiding, mentoring, and encouraging us always, and for encouraging various states to come up with their own webinars. So hereby we conclude the finale webinar for the day by Central Zone. Good night, everyone, and thank you once again.
Thank you, Dr. Isha, and I hope you can give a prize to Dr. Lavanya and Dr. Jay.
We sure would do that. Thank you, Megha. That was a great quiz. Thank you so much.
Thank you, everyone. We'll be closing the session. Thank you.